Are you ready to talk about menopause? I am. Stay tuned for more menopause on this next episode of Digest This.
Welcome to Digest This, the show that helps you revolutionize your digestive health. Here are your hosts, Dr. Liz Cruz and Tina Nunziato.
Hello, and welcome to Digest This. I'm Dr. Liz Cruz, and I've got Tina Nunziato sitting right here by my side. If you're watching us on YouTube, thank you so much for being here with us. If you are one of our regular listeners, we thank you for your loyalty, and we love you. And if you're a new listener, welcome, and we love you too. And we're so happy that you have found us. Today, we have a guest speaker, and actually, she's not even a guest speaker anymore because she's been with us before. She actually did another episode with us about a month ago.
2 months ago.
2 months ago, yeah. She did an episode with us, Dr. Finker. She is no longer a stranger to us. Welcome, Dr. Finker.
Thank you. I'm so happy to be here.
Yes, it's nice to have you back. Thank you
Yes.
for doing this again. So yeah, the last podcast we did with you was on thyroid
Yes.
hormones, which we had a lot of people jump on that podcast. So that was awesome. Thank you so much for doing that. And then recently you were like, let's do female hormones. And I was like, where on earth do you want to focus there? Because there is so many things we could be talking about. Girl, I am in the thick of it right now.
This is such a great one. I mean, and so I just want to put this out there because I know that we have all genders with us watching this. And if you happen to be a male gender, you should be watching this too, especially if you have a wife that may be going through this or will be going through this. This will actually be such a great podcast. So it's a great episode for everyone. And so, yes, Dr. Finkers, thank you
Just
for.
watch as we pull our hair out. Okay.
The three of us. Exactly. As we okay. And we may have lipstick on and look dressed, but hey, let me tell you. No, anyways, thank you so much for coming back to join us. We loved having you with us before, and so we are so excited about this episode. So much to learn.
Yeah, well, it's so great to be here, and it's a huge topic. So I appreciate you letting me
Yeah.
talk.
So we decided menopause. We wanted to talk about menopause. So tell me, why did you specifically want to talk about menopause?
So menopause is a problem. It's a problem for a lot of reasons.
That's the way to define it. I love that.
Yes.
But one of the main reasons it's a problem is it causes so many different symptoms. And a lot of doctors are not well trained and don't have an understanding of what women go through as we age. So I have patients come see me all the time with brain fog, with insomnia, with anxiety, with depression. And a lot of times they're not recognized for having hormonal dysfunction and they're just put on meds.
Yeah.
And
Yeah.
the
And
hormones aren't even
like you said,
addressed.
those are all the non-physical things, right?
Yes, yes,
Exactly, which I
correct.
appreciate you mentioning because there's plenty of physical things that come along with
Yes.
menopause. But yeah.
Yes. And then there's all the symptoms we think about, like the hot flashes and
Exactly.
the vaginal dryness and the low libido and all of
Yeah.
those things. And doctors often will recognize that as a menopausal symptom, but they don't have anything to offer, or they're not even testing blood work anymore a lot of times for these women. And now, because the government took the black warning label off of hormones, all of a sudden hormones are this big deal, but there's doctors prescribing it that have no training and no understanding, and they're not doing testing. So to me, this is probably one of the most important topics out there right now, and women need help.
Yeah.
I do. And I want to throw something in at the beginning because you're right that we as physicians, like going through my internal medicine, we didn't get a lot on female hormones and what to do with our females. I mean, we were basically like, here, prescribe them Premarin, like, like that's the one I remember from my internal medicine days. But even other stuff like, I'm just going to say this, I hope I don't offend anyone, but I'm going to talk about the clitoris, okay? Because this is something that I actually ended up recently doing some research on that, on how menopause even affects the anatomy, the clitoris.
Yes.
I didn't realize like low blood supply and that it actually starts to atrophy. And so
Yes.
that affects, on a woman being able to enjoy an orgasm and have,
Yes.
like all of that is so affected. I mean, I know you mentioned decreased libido, but even the anatomic physical changes that take place, I did not even realize that that stuff happened until recently. So
Yes.
I just think this is a great topic.
Yeah, and
Yes.
I was just reading an article about the legislation coming out now to help women because even insurance companies are not covering hormone replacement therapies
Mm,
and things like that. And so women who are suffering, and these therapies could be $500, $1,000 a month for them to be on, and insurance is refusing to cover it. And so now there's this new legislation coming out to say, no, we should be covering these things. This is something a woman is going through. We should be able to support that as a woman ages. So I think there is a lot of things happening right now around this, and so this is a really great topic.
Yes, definitely. So I hear all the time from my female patients that they have trouble having an orgasm now, going back to what you said, Dr. Cruz, or that they don't have them at all anymore. So there's that, which is just something that really needs to be addressed. And then insurance. So here in New York, I'm not sure Arizona, but here in New York, my patients sometimes can get covered for hormones, but it's not the right hormones.
Mm-hmm.
mm,
Either it's the synthetic hormones or it's not the right form of hormones. It's
Mm-hmm.
so
It's very frustrating.
frustrating.
Very
yeah.
frustrating. Yeah. So before we get into like how people, you've already talked about kind of how people present in menopause. Talk about, because the one thing that I've always had confusion around, and I know a lot of people that I do consults with, is the difference between perimenopause and menopause. Just to explain the differences between those two so that we can have kind of a distinct clarification there.
Sure. So perimenopause, I mean, and they can start almost at any age. I've had friends in their late 30s and, patients in their 50s and some even not until they're 60 go through menopause. So first we go through perimenopause where the hormones are up and down and all over the place. The period starts to get irregular. And then we're diagnosed with menopause when it's been 1 year since our last period. That's the
Yeah.
textbook definition. But oftentimes people will go a year and then they'll get a period again. So it's a little tricky, but in general, no menses for 1 year
Okay.
equals menses.
Okay, so you talked a little bit about how people present, both the kind of the physical symptoms and the non-physical. Talk a little bit about what your workup is for a patient when they present and you're like, okay, this sounds like this could be female hormone issues.
Sure. So I do a very comprehensive blood work panel on every patient that comes in with any kind of hormonal issues. I'm looking at all of the different hormones, the estrogen, the progesterone, the testosterone, the DHEA. Then I'm also running other markers that are related to the hormones. I'm looking at the thyroid. I'm looking at cortisol for the adrenal glands. I'm looking at sex hormone binding globulin. Like there's a lot of different things. So I'm running a really big panel to look at
Mm,
everything because everything is interconnected. And then, really important, which a lot of doctors, even in my field, leave out, you need to do a 24-hour comprehensive urine panel. And it cannot be a spot check urine, which a lot of the younger docs are jumping on that bandwagon. I get it, it's easier for the patient, but it's
mhm,
not giving us a complete picture. It has to be that 24-hour pain in the neck,
mm,
Mhm.
urine collection in a big jug kind of thing.
Okay.
From there, we're able to see how all those hormones are metabolizing. And
mm,
this is really, really important. I just had a friend who is perimenopausal. She went to the doctor. The doctor's like, oh, here's all the hormones, including testosterone. Now, I know this friend very well. She does not need testosterone yet.
mhm,
Maybe eventually, but not right now. And the problem is if you just look in the blood work and you look and you see, oh, the testosterone's low, you're not going through all of her symptoms, recognizing she still has a high libido. She's still
mm,
breaking out, that kind of thing. And when we run the urine, I'm sure if I ran the urine on her, her testosterone metabolites would either be normal or high.
Okay.
So we have to run the urine because you could have a teeny bit of testosterone or it could be even overtly low, but the body still knows how to metabolize it and it's
Mhm.
still utilizing it. So you don't want to give hormones in that case. So
Okay.
that can never be left out. We always have to run that. And I'm fortunate that I work with other doctors that are experts in my field that over the last like 15 years or so have collected all this data and they have very good parameters of those levels.
Okay.
So they really are able to see what's going on there.
Okay, wonderful. So what are the different results then when you get these test results back? What's the typical blood and urine results telling you?
Usually, if someone's been in menopause and it's not perimenopause,
Mm,
perimenopause, they're all over the place. It's a lot
yeah.
harder. Usually, everyone's pretty depleted. Usually,
Okay.
their levels overall are pretty
Hormones?
low for all the hormones. Sometimes, you'll get a rare case where someone's estrogen still looks okay going
Mm,
into it, but their progesterone is like non-existent and they're estrogen dominant. So sometimes in those cases, they're still having issues with fibroids and other things. But usually across the board, everything's low and we have to balance everything. And then we want to bring everything up to the levels that are optimal for our age. We never want to be 16 again.
right. That makes sense. So are you, so you would treat a woman who was 65 different than you would treat a woman who's 85?
Yes.
Okay. Okay.
Yes.
Talk a little bit about
But
that.
but I would treat everyone at
Yes.
any stage. So
Yes.
a lot of new research has come out, especially about the hormones. It since I mean 2003 was Premarin, which is essentially horse urine. Like who
Exactly.
wants this?
Wow. I
As
know.
much as I love horses, I don't want their hormones. So the last, like I would say, 7 or 8 years, like we've really got a lot more information because we used to be told, oh, if someone's 83 years old, you don't look at hormones.
Hmm.
But if someone's 83 years old and they're not able to stand up and they're having severe, well, not severe because then by then it's probably too late, but cognition issues that are mild, they might be a good candidate for some testosterone, estrogen, and the other hormones as well, and it
If
could
they're
potentially save their life.
Yeah,
Yeah.
that or if they are active and they're still living a great
Yes,
life, or then
yes.
that right, exactly. Yeah, they want to keep active and
Yes, and
be
then maintaining, yes. And,
exactly.
with the bioidentical hormones, even though they're much more natural, that kind of thing, there is much less risk. But you have to have an understanding of the risk. You really want someone who's trained using the hormones at the right levels, which is
Hmm.
so important. You don't want to use too little so there's no therapeutic dose, but you don't want to use too much. And a lot of times patients will feel great, but I'm like, you're overusing. You feel great. It's almost like you're using the hormones like a drug long term. I don't want my patients having any issues. We really get the risk as close to zero as possible.
Hmm.
And oh, go ahead. Oh no, I was just going to ask you. So, as far as the hormones that you use, do you tend to use more of the bioidentical for the
Yes,
most part?
I only use bioidentical.
Yeah.
That's what I was trained in
Okay,
23 years ago.
that's awesome. Actually, I didn't realize that they've been out for that long. I know, I was just asking if you could explain to our audience the difference between bioidentical hormones versus the non-bioidentical, which I'm assuming would be the traditionally prescribed hormones, correct?
Yes, so the synthetic hormones like Premarin have the molecular structure of horse hormones.
Is Premarin still out there?
I don't know. I hope not.
That's what I used to use like over 30 years ago. So
Yes, and that's, that was one of the only things we had access to,
exactly.
30
That
years
was
ago.
it. That was it. Everyone went on Premarin.
Yes, yes. And then they did that women's health initiative in 2003, and they're like, no hormones now, hormones are bad. But in my field, they look very closely through that, and they're like, no, this is not a good study. They knew back then that it wasn't a good study. They're like, in the right circumstance, we're still going to prescribe, the bioidenticals. And they were
Mhm.
right. I think it was in 2017, they finally started to retract the Women's Health Initiative, and they're like, no, this
Yeah.
wasn't the most accurate finding. And
How many years for them to
Of course
pull
it
that
did.
back?
Of course it did.
Wow, wow. Okay,
yeah,
okay. So synthetic versus
yes,
bioidentical.
sorry.
Okay.
So the synthetic hormones look different than our hormones. It has a different molecular structure. The
Hmm.
bioidentical hormones have the exact same molecular structure that our hormones have. It's
Okay.
exactly the same. So our body knows how to utilize them, how to process them, and there's much less contraindication and issues with the bioidentical hormones. And we're
Okay.
really seeing that. At this stage of the game, I don't think, unless you need birth control so you don't get pregnant. Other than that, I think the bioidenticals work better in most cases for patients, and
Hmm.
it's safer.
Okay.
And what are the risks? You mentioned trying to get the risk factor down to 0. What are the risks associated with taking these?
Yeah. So first off, with the synthetic hormones, with estrogen, if you're taking it orally, like the Premarin, then there
Hmm.
is some increased risk of clotting.
Okay.
So I never give my patients oral estrogen ever.
Oh, so that clotting risk is only for the oral.
Correct.
Really?
That's
I
what the
didn't
studies
realize that.
are
Okay.
showing. That's
Okay.
what the studies are showing. And there's no reason to use the oral estrogen, like I said, unless you're protecting yourself against getting pregnant. The bioidenticals don't work that way.
Okay.
But otherwise, to help mitigate all the symptoms of perimenopause and menopause, topical works just as well pretty much every single time. And then the topical hormones that I work with are amazing because there's no solvents in them.
There's
It's
no what?
just no solvents.
Solvents. Okay.
They're solvent free, so it's
Creams,
amazing.
is that do you use like when you say topical creams or patches? What are you
So
talking
so
about?
the patches will have solvents in them, but still, if
Okay.
we're gonna pick oral estrogen or the patch, I
The
take a
patch.
bioidentical patch any single time
Okay.
over
All right.
that. But anything to get into the skin needs a solvent. But the doctors that I work with created these organic bioidentical hormones that they've been using now for over 10 years that get absorbed into the body without having to use solvents. And they've done study after study proving its efficacy, proving its absorption. And all it is organic jojoba oil. It's amazing.
Oil.
That's awesome.
Yeah.
So so is there like one oil for estrogen, one oil
Yes.
for testosterone?
Yes.
Okay.
It makes it a little harder. There
So
is
they
a
don't
little.
compounded version of whatever combination you need. You'd have to do a little bit of each one depending
Yes.
on what you needed.
Yeah.
Okay.
So there is more work involved. You have to like shake it and you have to, put a few different little creams on. But I'm like, to have a lifelong free of solvents, I
Yeah.
think it's worth it. I think
Yeah, for
it's worth
sure.
it.
And then do you dose it again based on the age of the woman and like
Yes.
what their results show? So you were like, okay, you would need 2 drops of this one, a drop of this one. Is that how it works?
Yes.
Okay.
Yes. And then you test to see.
Okay, how you test it
Yes.
after. So that
Yes.
so first question is you put it on just once a day?
So it depends. Every patient's different. In general, you're going to be putting the estrogens on in the morning and the progesterone's on at night. And then the DHA testosterone, it depends. Usually that's the morning too. But progesterone, you always want to do at night because that's what helps with sleep.
Okay.
Mm.
And then once someone's been on those, how long are they on them before you retest them and are you retesting them with the same tests?
Yes. So I usually have patients on them for like a month and a half, 2 months, sometimes even 3 months. It's very patient specific until they're feeling better.
Okay.
And then we retest with all of the same tests.
Okay.
And then it's a combination. I want them feeling better, but I also want those levels to be optimal. Because sometimes, hormones make you feel really good and you could be overdosing on the
Okay.
hormones. So we
Got
want
it.
to keep everything so it's at a good level where it's as safe as can be and also it's working and you're getting the optimal effects to prevent against the issues that we get as we age, like falling
Yeah.
or not having good cognitive function, those kind of things. And
So even with the bioidentical hormones, are there risks with those and what are the risks associated?
so with any hormones, there's gonna be, some risks, especially if you're not following up, you're not testing, and you're not watching. It seems like, though, from the studies, it's pretty amazing. I mean, it seems like it's not, I can't even say it because I still can't fully believe it, but it's
Okay.
not increasing our risk of breast cancer,
Okay.
which I still can't wrap my head around. And there's doctors that are more well versed in reading study after study than I am. But it seems like if you're on the hormones done the right way, it actually decreases our risk. But the caveat is if, God forbid, someone has breast cancer, it's going to increase the growth of the breast cancer. So you have to, unfortunately, but you have to be doing mammograms and you have to
Right.
play it safe and make sure there's nothing going on if you're going to do hormones and internal sonograms too, just to be on the safe side.
Right. And once you get somebody at the levels that you want them and they're feeling good, how often should they be tested?
I mean, you could usually get away with once a year then, as long as
Okay.
they're feeling good and they're not having any problems, once a year.
And do you find that those hormones that you're using are covered by insurance, or are women paying cash?
They're not covered by insurance. That's what makes it so
Yeah.
hard. And sometimes they opt to, just go to their doctor and not pay out of pocket. But I'm like, for long-term health, it's not the way to go, unfortunately.
Oh,
And I don't know, with the alternative stuff, it's so hard with insurance, as you guys
I
know.
know. I
Yeah.
know.
Yeah.
How much is it for, someone that's in menopause that needs to be on a little bit of everything per month? How much have you found about does it cost?
Sure. So it's usually $350 per month,
Okay.
around that. It
Okay.
varies state by state, but that's usually the cost for
Okay.
women. Of course, for men that go through andropause, they only have to pay $250 a month, but that's just
Okay.
what it is.
What's your opinion on the pellets?
Oh gosh, I hate pellets. I'm not.
Well,
I hate pellets.
tell me why. Why? Because
So,
I still have women that tell me, "Oh, the pellet, that's the way
so
to go."
they'll
And
feel it's easy. They'll feel
mm,
great. It's easy. I hate them because if, God forbid, something happens, like
Mhm.
your body, starts having breast cancer, that kind of thing, you have to have surgery to have them removed.
Wow.
My best friends, it's like the status story. My best friend opted to do pellets. I was like,
Mhm.
please do not do pellets. Please have them test your urine. Please go to a doctor. If not me, then one of the doctors that work for me that have an understanding of all this. And she went on pellets and she got breast cancer. And the hormones are going into her body. And I just, I hate pellets. I wish they
Yeah.
were legal, honestly.
and they're usually placed they're in the office, right? Don't they
Yeah,
place
it's
yeah,
not like they're doing, crazy surgery or anything. They just put them in,
yeah,
but then to take them out, that it's like a process to take them out, and they don't take them out. I mean,
Yeah.
they didn't take them out of her, and and she was going through, chemo radiation, like, and it was just awful. I'm like, this really is something. I get it. Like, it's easy. She felt great. She's like, oh, this is the best I felt in my life. I'm like, I get it. It's cumbersome. You have to like shake these bottles. You have to remember to put on everything. But to me, I'm like, there's no comparison.
Yeah.
mhm.
No, I totally get that, and that makes sense. What about if somebody has low cortisol levels? How do you manage that?
So low cortisol, that's why we test all of the hormones. It depends. It depends how low it is. It depends what's going on with the patient. So sometimes there's different supplements that can help with that. One of my
Okay.
favorite supplements is called Stabilium. All it is fish protein. That's all
Oh,
it is, from off the coast of France.
okay.
And that could naturally bring up that cortisol. It's also balancing. So I don't even always have to test with that. If the cortisol is too high, it brings it down. Too low, it brings it up.
Mm,
But then
Mm.
there are some patients that are so depleted that we do bioidentical cortisol with them.
Oh,
wow.
okay. All right. That's not, and it's saying oil-based, like one of the
Yeah,
like the hormone.
yeah,
Okay.
it can be. It can be. Or that you can do orally, but sometimes when you do that orally, it can irritate the upper GI. So
Hmm.
especially for GI patients, topical is best.
Sure.
Yeah, and I know when we talked to you a couple months ago, we were talking about how you're based in New York, but you work virtually, and
Yes.
you do have patients here in Arizona, which I love. And so,
Yes.
the company that you work with for all the bioidentical hormones, I assume all that can be formulated and shipped anywhere
Yes.
in the country,
Yes.
which is
Anywhere in the
amazing.
United States.
Yeah. And all your testing you can do remotely. So you send people to labs and you tell them, go
Yes.
do this blood test, and you can go through all those results with them on the phone, which is awesome.
Yes, yes. They just need to be in the US. Like I have patients in Bermuda and Mexico. I'm like, you guys, you need to come here if you want to do that.
And are you doing your labs through the standard labs, LabCorp and Request, or do you have a special labs that you use?
I actually like LabCorp and Quest for the
Okay.
basics.
Okay. Good to
We
know.
try to use them. New York's a little tricky, but every other state, LabCorp and Quest for the most part.
Okay, perfect. Oh, that's awesome.
Yeah.
Yeah.
Well, I know that I do a lot of consults with women around our age who all of a sudden are now having digestive issues on top of all of the typical menopause symptoms as well. And they're always like, could this also be menopause? And I'm like, yes, everything in the body gets kind of messed up when our hormones get messed up. So, yeah, I
Yes.
feel like getting those hormones checked and getting them in balance can help so many things in the body. People don't realize how interconnected everything in our body is and how important those hormones are for driving overall health
Yes.
in our body. And, you just think of it during your teenage years and then you think of it, oh, menopause, but we don't think of it affecting GI issues and our mental health and so many other functions in the body that those hormones affect. So
Yes. I always say they're tiny little molecules, but they pack a big punch.
that's
They're so
exactly right.
important.
Yeah. Yeah. That's awesome. All right. Anything else you want to share that you didn't get a chance to share that you think would be helpful for everybody to know about menopause?
Yeah. So I always tell everyone that we don't have to fall apart and feel horrible as we age. That definitely does not need to be the case, that there is so much we can do to help our body with balancing the hormones, with increasing our hormone levels. And it's something where we could literally be running around playing tennis, horseback riding, ballroom dancing. I have women in their 90s that are still competing as
That's awesome.
ballroom dancers. And they
Yeah.
feel great. They don't have pain. They don't have cognitive decline. They're able to get up off the couch quickly, not over the course of like a few minutes kind of thing. So,
Yeah, that's the thing. If we
Awesome.
stop using it, we lose it.
Yeah.
And I find that the more active you can stay, the better not only physically the body is, but also mentally the body is. And that's one of the first things when we start to feel tired and have low energy and we don't want to get off the couch, and then the aches and pains start, and then that really doesn't make us want to get off the couch, and then that's it. That's the decline, right? It starts with the
yes.
physical and then leads into the cognitive. So, yeah,
Yeah.
I think the faster you can jump on those things and stay on top of your health and stay active, the better for your
Yeah.
overall longevity.
Yes, I have patients all the time in their 60s, 70s, sometimes even in their 80s, and they're like, I feel better now than I did in my 40s.
Right.
Wow, that's great.
Yeah.
I love the message of hope that you're giving because, like Tina said, we have so many clients and patients that are probably suffering unnecessarily,
Mm-hmm.
you
Yes.
know, and
Yes.
are looking for hope. So thank you so much for sharing that there is hope. And I mean, that's so great. You have patients in their 90s that are ballroom dancing. I mean,
Yeah.
that's
Competing. Still
amazing.
competing.
Yeah,
I love
and
that.
honestly, $350 a month. Okay,
It's
like
worth it.
first of all, screw insurance. Okay, it's fine. If it's not going to be there for us, we have to invest in ourselves.
Yeah,
Okay,
Yes.
when you
absolutely.
think about $350 a month, it's like today it's going out to eat 2 or 3 times.
Yeah.
Okay,
Yeah.
honestly, just cut back on your going out to eat or your coffee or whatever, and invest in yourself and take care of yourself so that you can live a happy, healthy life
Yeah.
and continue to have orgasms. Okay, did I
Yes.
just say that?
Yes.
It's an organism.
That's so important for our health. It really is.
Exactly. Oh, well, thank you
Thank you
again.
so much.
Thank you both.
Yeah,
All right.
wrap it up.
Yeah, I'm sorry. I was just thinking about the orgasm. Oh, thank you so much. You like that? Sorry, I just got a little. That is daydreaming. Thank you, Dr. Baker. so much.
Oh, you
Well,
guys
this
are
was
so much fun. We have to do this again. It doesn't. It's
I
just like
will, we
hanging
will.
out. It's great.
Yes, yes. And you, for you out there that are watching this or listening to us, if you haven't checked us out on our website, and I know my thoughts are all over the place right now, but if you haven't subscribed, first of all, subscribe to the podcast so that you never miss an episode. You absolutely never are going to want to miss Dr. Finker. So definitely subscribe. If you haven't rated us, rate us and give us a 5. It's going to help other people just like you to find us faster. You can connect with us on our website, drlizcruz.com. You can subscribe for a free 3-minute wellness consult, and that's over the phone, so you can do it from anywhere in the world.
And I'll add Dr. Finker's info too in our little blurbs that
Yes,
if you all
yes.
want to reach out to Dr. Finker, you can.
Absolutely. And also subscribe to our newsletter that goes out every couple weeks. And we'd love to hear from you. You can email us, you can call us. All that information is on our website. Thank you so much, Dr. Finker, for being with us today. For all the wonderful information and the entertainment. And we thank you for being with us, and we'll catch you on the next podcast.
Thank you for joining Dr. Liz Cruz and Tina Nunziato. To learn more about their revolutionary products and services, go online to www.drlizcruz.com.